So our next presenter, Dr. Ying Wei Wang, Director of Palliative Care Center at Hoa蓮慈濟Hospital. His topic today is integration of spiritual care into palliative care services. Let's welcome.
Thanks for the introduction, and thanks for having me sharing the experience in Taiwan. May I have my first slide? Because I'm working in the hospice. Actually, we set up the first Buddhist hospice in Taiwan about 28 years ago in East Taiwan. And I'm launching, we can look at the spiritual care in another aspect because we are talking about the chaplain, but actually spiritual care is everybody's business. So look at some of the basic information about the palliative care. We noticed that the quality of depth of care globally. There is a survey in 2010. Among 40 countries, Taiwan ranked number 13 and number 1 in Asia. And in 2015, the quality of depth index, there's a comparison between the quality of depth among the 80 countries. Taiwan ranked number 6. And I write a case study. They asked me to say something. Why did we change, improve from number 13 to number 6? Because the community engagement, also the discussion of life and death into the education system from primary school to the university, means that Taiwan started to facing the life and death even in the primary school. There's some discussion since the primary school. And the most recent report in 2021, and there's among 81 countries. Now Taiwan, the quality of death, Taiwan ranked number 3. In this new comparison, there are another indicator, not only the structural indicators, but also the quality of communication and the quality of care. Among these indicators, including the spiritual needs for the palliative care. So I think that it's really important if we are going to provide our best quality of care, we need to spiritual care. Also, to place of death, also the patient can ask more questions and treat kindly. And this is the definition of the palliative care from World Health Organization. This is to integrate the psychological and spiritual aspects of patient care into the end-of-life care. This is very important. And just mentioned the history in 2017. I have a chance flying from Taiwan to the Vatican cities because they are reaching the World Charter Palliative Care for Older People. In this time, Zhongzhen Huasi is coming all together, and we write the charter. We signed on the World Charter for Palliative Care for the Older People. So there's a lot of discussion about during the conference from different religions. And the leader is from the Christina Pachaska. She's coming last month to Taiwan, and sharing some of the experience about training for the palliative care, not only for the chaplain, but for everybody's. So this is the content, the spiritual and religious perspectives. But let's skip this one. And also in the United States, there's clinical practice guideline for quality of palliative care. There are many domains. And in the domain 5 is about the spiritual, religious, and existential aspect of care. That means that if we are going to provide a good quality of care, we need to provide all these domains. But there is also a report in the spiritual care, in palliative care. They mentioned that although recognized as the WHO as the essential domain of palliative care, but still most neglected component of the healthcare system. That means that we emphasize this is really important, but we still need some more training for the spiritual care. And they start up some of this in the European Association of Palliative Care. They started with a so-called spiritual care task force and developed the training, education, and research program. And there's a reference scope, and also writing the right papers. There's also sort of core competence of the palliative care physician or providers, and including the there are 10 core competence, and the number 5 is the meet of patient's spiritual needs. So there is still need more training. And in Scotland, in UK, they think that this chaplain training may be the A levels, means that this is the highest level. but it should be all NHS staff. Everybody should be trained for the spiritual care. And the B level is those that are taking care of the patients facing death very commonly, just like the palliative care team. So it means that spiritual care should be training for all the 3 levels, not only the chaplain, but also for those taking care of the patient or facing the frontline physician or frontline workers. There's also in Australia, there's a national guideline for spiritual care for the all age in aged care. It means that all aged care staff should have some spiritual care training, and also for those with spiritual care professional, and also some of the faith representative. This is 3 level also. So this is spiritual care, pastoral care, and also religion care in their proposed training program. So this is they said all aged care staff should provide certain kind of education and training, and those with close contact with caring for patients and elderly should provide more training, and also the faith representative has some different kind of training program in their levels. But we also want to mention about spiritual care. Sometimes we use different words: the person-centered care, relationship-based care, well-being, wellness, aged care, holistic care, alternative therapy. All these are related with spirituality. And we noticed that dying is not just one thing, it's a 4 dimension, including the physical, social, psychological, and spiritual. In the past, for those working with the end-of-life care, we almost focus on the physical part, the patient, the condition, the rapid tragedy, just like the cancer. We notice the physical condition gradually downhill. But at the same time, there are some changes of the social decline, and also psychological decline, and also the spiritual decline. So this is the thing that we treat the patient as a whole person. We need to look at the 4 aspects, 4 domains of the patient. And from the Lancet, there's different kind of a dying process. One is cancer, the other is organ failure. There's a heart failure, renal failure, liver failure. Also, a really common is the frailty. You notice that this is the 3 different colors. One, the yellow color is the spiritual. For cancer, the variation here. And the organ failure, the spiritual care is this line. And also the frailty is almost the same as the psychosocial decline. So when we're facing the patient with different physical or health systems, we have to approach a different approach method. But now more and more people are dying with multimorbidity because of the elderly population. The patient will have a heart failure, frailty, or cancer. So the fluctuation is quite a variation. This is why that the first-line healthcare provider should have all these concepts when we're taking care of the patient as a whole. How about the spiritual input for the health professional? I just mentioned that there's a book, Professional Christina Petresca. She's very famous in the United States, I think. She proposed a lot of spiritual training program in the state. And there's a book, Making Healthcare Whole. And they said that actually everybody should take we are going to take the spiritual history when the patient admit to the hospitals. As we are working in the hospitals, we notice we have taken the social history, the family history. But now, can we take the spiritual history when they admit to the hospital? This will be a very fast and easy way, but very precise way. Maybe you can just ask questions. What's the most important to you right now? How can we help you? This is all these very simple questions, but once we ask this question, we can take alert of the patient's spiritual aspect. And also there's a training program online. So in the professional spiritual training program, she proposed, I have joined this program now, and I learned quite a lot from it there. And also there's a very special report on the national and international consensus. They said spirituality is also a compassion. It's working together, and then the patient outcome, and also for the healthcare professional outcome. The patient feel more satisfaction, and also for the healthcare provider. So spirituality and compassion should be working just like that simultaneously. And not only for the patient, but also the staff. Well, as a staff, we have to create our compassion and self-awareness, and also our professional skills. This is the training for even the providers. So this book, I like it. So what I said, talking with patient about spirituality. We translate it into to Chinese, and then we train our staff how to communicate with the patient, talking with the patient, what kind of phrase or response that we can respond to the patient. Let me talk something about our hospice, because we just mentioned while working in the end of life care. This is the painting by one of the volunteers by his mouth, because he lost extremity during the electric shock. And this is the Buddha in the center. And there's two phrases. The heart is like the bright moon, illuminating the purity of the word. And the lotus, as the Buddha blossoms the flowers of wisdom over the human world. This is the painting that on our hospice in East Taiwan. And there are many people visit our hospice, and also we always emphasize patient is the center, and everybody around the patient, so we have to serve them. And we have different religions. And for the caring of the patient, actually every practice is some related with the religious, spiritual, because we introduced the aromatherapy in Taiwan 25 years ago. During the aromatherapy, the communication, this is kind of also of spiritual care in action. And also we have the art therapists. You know that we train our staff for just using one skill, how to draw a bridge, the bridge. So this is one of the result of the painting from our patient. And when they take draw a bridge, they ask if there are Buddha at the top. If there's the Guanzi Yin in the top, they can guide them from one way to the another side. So this is the art therapist in the hospice also. We're also doing some of the live review. And live review is also a story, a narrative story. And the volunteer, also the students trained for taking of this live review and story for the patient and the family. And as Dr. Lin said about the compassionate spiritual company, compassionate presence, so we have different religions coming together to in the unit. We have some research, local research. Professor she just passed away 5 years ago. He is a very famous clinical psychologist. He wrote a lot of books, studies in our hospice, and it is using the local culture and about the phenomenon of terminal cancer and culture issues, and also about the spiritual care for the patient and art therapy for terminal patients. There are a lot of certain kind of local research on the spirituality. And he always emphasized that we can treat the patient heart to heart, brain to brain, not brain to heart to brain. This is very, very simple, but very important in communication. If the patient says something from their heart, we have to respond with the heart. And this is one of my students doing one of the master thesis in Chichi University. And the comparison of the hospice promotion film between Western and Eastern countries. As you notice that the Eastern country and the culture, the communication still is not, the culture is different from the Western and the Eastern. We started from the Western culture, some of the video film from America, Canada, British, and Eastern film from Taiwan, China, and Japan, and also mixed culture film from Hong Kong and Singapore. And this is the high context culture, and this is low context culture. Low context from the Americas, Canada. The Eastern culture is the high context. This is film promoted by the Hospital Foundation of Taiwan. When we say that this is the Western culture, this is strict communication. So we have to talk something about the life and death. But in the Eastern culture, we need to, just like the Four Seasons, you have to communicate. You have to say something indirectly with some story before you directly communicate with life and death. And we use this one first and then use this second. And then it's very easy. If you change them, the directions, that would be typical for communication. And we have some of the promotion film from Chichi channel, talking about the ACP and SDM, and we have some pamphlet. For the new movement in hospital and palliative care in Taiwan, we are now, first we have doing the cancer and also the hospital care, shared care. But now we move to the third hospice movement, including the long-term care and community. And also we propose about the compassionate communities and compassionate cities program in recent few years. And for the compassionate communities, actually we propose that in Taiwan, also in the East, in Hualien. And there's a 4 dimension about the compassionate individuals, compassionate relationships, compassionate organization, and compassionate communities. And we are now writing some of the proposal on, because we hope that not only dying at the hospitals, but they have to take care at home. Home is the best way that they can stay. So we need a lot of, not only the physician, but also other, because for informal care, in the last year, 95% of the day stay at home, and only formal care, only 5%. And Professor Alan Kennedy said, death is a social event with a medical component, not a medical event with a social component. And this is very important concept that we need to promote end-of-life care in the communities. And also from last year, the epidemic of loneliness and isolation from the Surgeon General in the United States, they said lack of social connection is more highly risk than smoking or drinking or physical inactivity. So social connection is one thing that we need to target in the communities. We show some of the program in the past. In the training advocates, we have a training program for this is in the training program and also in the hospitals. And we have doing some activity during the ceremony. And also we have a compassionate conduct in the Church University. We try to educate our students that they have certain kind of concept. And for the Hospice Palliative Care team, from the Hospice Foundation of Taiwan, last year we organized every month their webinar about training for the nurse and physician about the spiritual care, not only for the chaplain, but also for healthcare providers. And this is very important concept that in the past we focused on the blue one is the specialist, but now the generalist and also the compassionate community, and also we have the movement for compassionate spiritual care and compassionate model as a whole. So this is important. We have to kill sometimes, to live often, and to cover always. And Teresa said that we can purely cure physical disease with medicine, but the only cure for loneliness, despair, and helplessness is love. There are many of the world who are dying of a piece of bread, but there are many more dying for a little love. So love is just, I think it's very important. I use your logo. This is my final presentation. Thank you.